Tuberculosis continues to pose a severe threat in Uganda, with an estimated 240 people contracting the disease every day. The bacterial infection, which affected 96,000 people across the country last year, thrives in crowded environments. According to Dr. Mwebesa, Director General for Health Services, TB hotspots include markets, schools and prison facilities.
This CAS TB was first implemented in 2022 and led to identification of 100% of the targeted TB patients that year. Since the inception of CAS to date, over 220,000 new cases of TB have been identified. The lessons learned from this innovation informed the design of the integrated community awareness screening and testing for TB.
In high-risk areas like Uganda's prisons, Dr. James Chisambu, Assistant Commissioner for Public Health, emphasized that the prison services has implemented robust measures, including mandatory screening for every inmate upon arrival to prevent the spread of TB.
We have cough monitors on every ward where the prisoners sit. If someone coughs at night, these people are taken for a TB screening the next day to make sure that if the TB starts, we need to catch it as early as possible. Again, to reduce the transmission cycle, to break the transmission cycle and reduce the number of people that actually get infected with the TB. And then thirdly, we carry out routine mass TB screening in the prisons. Every quarter, we go and screen as many people as possible. Any person that has any sign or symptom suggestive of TB, we rather do a full TB screening to that person and make sure that he doesn't have TB. We isolate those ones that we have identified as TB or diagnosed with TB. We isolate them and treat them separately.
Meanwhile, Dr. Stavia Turiahabwe, Assistant Commissioner for TB and Leprosy Control, provides further insight into ongoing efforts to combat TB as a significant public health threat.
We are also working closely with the prison services to see how best they can improve on the ventilation while maximizing security at the prison services.
So we also know that about 15% of the total population of people living with TB are children. And we understand that screening children is not as easy as screening an adult. How are you working around to ensure that you actually capture the infection within the young ones as fast as you can and then enroll them on treatment? But also, is the treatment the same as for adults?
One, we are building capacity of the health workers on how to combine the different signs and symptoms to help them in coming to a conclusion of TB, especially in those where they cannot pick a sample. But also, most recently, we have introduced the use of stool. The very young ones, when they cough, sputum comes up, they swallow it. So this sputum will go with the germs in the stool. So the gene expert can be able to now detect this TB by when the health workers process this stool, they can identify that germ. So the treatment, we use the same medicines for treating TB in children and adults. Now the duration is the one which we have reduced. For children who do not have severe disease, we have started looking at reducing their duration of treatment from 6 to 4 months. We have initially started with the regional referral hospitals because there is a criteria that you follow, including the use of the chest X-ray to rule out severe lung damage. And we know that this is more available at that level, and we should scale up this to other hospitals that have this service to make sure that children without complicated TB are given treatment for only 4 months.
My name is Walter Mwesigye, and that's all we had for you. Good evening.